Hi, everyone. My name is Mona Kwong, and I'm the Pharmacy Addictions Fellowship Program Director. And I'd like to welcome you and introduce you to Rahim Janmohamed. He's a Shoppers Drug Mart Addiction Pharmacy Fellow with the BC Center on Substance Use and a graduate of UBC in Vancouver, British Columbia. He has over 20 years of experience in community practice, is very passionate about patient advocacy for vulnerable and stigmatized populations, particularly in the context of addictions. So in the future, Rahim hopes to help bridge gaps of communication for patients from the time they enter and leave a facility or hospital to ensure continuity of treatment or consultation. Rahim wants to reach out to those patients or care teams that have patients with substance use disorders requiring more personalized care. Also, look to find new methods to support community groups, recovery homes, and care teams that require pharmacists to be involved in the safe and effective medication and consultation on treatment programs and help with the current state of emergency of the opioid crisis. So I'd like to welcome Rahim. Thanks.
Thank you, Mona. I really appreciate that introduction. It's been a great experience right now being as part of the fellowship program with BCCSU and Shoppers Drug Mart. I think that going through this, it's going to be a little eye-opening and some refresher for some of you as well. Firstly, I would like to begin by acknowledging the land that I am a humble guest on, the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. I respectfully acknowledge this, and I hope that each one of you can do the same. We do know how colonialism has affected a lot of people, and I do respect them and respect the land that I'm currently working on. As for conflicts, I have no conflicts of interest, no conflicts to declare. So as we begin today, during today's presentation, I'm going to be reviewing the fentanyl patch system. We will review methods of transdermal medication distribution, go over fentanyl patch mechanism, and I will also touch on some pharmacology, kinetics, safety, as well as some indications for treatment. We will then switch focus to the current state of the opioid crisis and review some of the information how it relates to fentanyl use. This will lead me into some fentanyl-assisted patch programs that are in process of review and some that have completed as well. I continue to have an optimistic approach on the current state of emergency in regards to the opioid crisis. If indications align, there are potential alternatives or add-on options for treatment and support of our patients and for those individuals with opioid use disorders. I believe with putting some time to learn from patients with lived experiences, those social workers, physicians, clinicians, health professionals, and those members of the public that are keen on supporting the need for support, solutions will come and continue to arise. Protocols for treatment continue to evolve, and the discussions continue to happen how this crisis has escaped us. I know there's some hope, but we all need the engagement, encouragement, and communication so that more developing solutions are on the way. As for my objectives, I will be reviewing the pharmacology of the delivery system of transdermal patches, and I'll also be discussing some fentanyl transdermal patch usage as well. That's on the screen there. As you can see, that's the molecule of fentanyl. That's just depicted there for you. And I will be referring to that later on in my presentation. So we're going to start today with just describing some transdermal medication delivery history. As you can see on this chart, if we look at our, on the left, we have our y-axis, which shows the development of the number of patches with different medications on treatments from about 5 or so, I think till about 50 plus. So the skin itself on the human body is about 1.5 to 2 meters squared, and it does allow for an opportunity to deliver medications transdermally. On the x-axis, as you can see the dates, it's ranging from 1981 all the way until 2014. the long range of time there depicts on the actual bars as well, the differences between all the patches that have been created. And on the side, you can see the color scheme for the style of patch. Patches move from a puffier style, more of a Band-Aid type, to more of a sticker type, quite thin, almost like a thin strip or like a sticker that you would or a piece of tape, basically. So the color chart shows the evolutionary changes of the patch as each style has a different name and represents the nature of the patch. Some examples are the reservoir, which we've known as the Duragesic fentanyl patch, and also the matrix, just to list a couple. Drugs have been applied to the skin to treat superficial disorders, for transdermal administration of therapeutics, to manage system ailments, and also the systemic absorption of drugs that have been applied have been used throughout history. It's also dating back to the initial medical records and time. The first modern adhesive transdermal delivery devices were developed through experiments in the 1960s, in which they were able to modify the extent of systemic absorption of salicylate esters via diffusion cell glued to human volunteers' forearms. The molecule in the earlier slide back here was fentanyl. It's a large molecule that is fat soluble, and this is why the method works for its delivery in patch form. The routine use of transdermal delivery systems only became a common practice in the latter third of the 20th century, when delivery technology was developed to enable precise and reproducible administration through the skin for systemic effects. Hopefully that's not too much information on the slide. There's quite colorful, and we have a lot of different types of patches out there on the market. All right, next slide. So here's a side profile of patches that were created. The development was a passive, non-invasive transdermal patch over time. Current patches on the market are thinner, as you can see in the fourth diagram, versus the first one, which has multiple layers and the reservoir. Each component of the patch is listed and gives an understanding of how they work. The backing in blue, the dots of the drug, and as you can see, the membrane there is kind of like hash marks from the 1970s to 1980s. And then the membrane in the that actually changed to just having the dots in the actual glue formation in matrix patch 1 and matrix patch 2, and then the drug in adhesive patch. So basically, it's changed over time where now the drug is in the adhesive, where prior it was also kind of lifted just a little bit above, just like a reservoir, but there was no membrane attached. Over time, the drug development process made the products a little thinner and easier and more uniform for drug distribution. There are two general types of transdermal delivery systems for the fentanyl patch. The Duragesic, which is the old technology. The original transdermal therapeutic system, was also called the reservoir transdermal device, was made by Janssen and the brand name Duragesic, and generics followed as well by Sandoz, Watson, Bricara, and Actavis. They consist of 4 functional layers and a protective peel strip. The first layer is a polyester film backing that prevents leakage of the transdermal device contents onto the surrounding skin. The second layer consists of a drug reservoir. The drug reservoir, which contains fentanyl and ethanol combined with a hydroxycellulose gel. Ethanol contained within the gel acts as an organic solvent to approximately double the rate of diffusion of fentanyl into the stratum corneum. The quantity of fentanyl contained in this reservoir is appropriate to produce a sufficient concentration gradient for transdermal absorption through a 3-day cutaneous application. One of the key points to consider is that the reservoir accounts for the possibility of dangerous leakage onto nearby skin. It's kind of like aloe vera gel, where if it leaks out, that's what it actually feels like. So that's one of the precautions when they were using Duragesic, and it's no longer made at this time. The third layer, which is just an ethylene vinyl acetate copolymer, adds the rate controlling membrane. It regulates the rate of delivery of fentanyl ethanol mixture onto the skin surface. As we move forward and go to the fentanyl generic, product M, otherwise the matrix patch, is flatter. It consists of two functional layers, a protective peel strip and the medication layer. The backing layer of the polyethylene film just comes right off, and then you have, there's a polyethylene film and then a fentanyl containing silicone adhesive layer. The major difference is that it does not contain an ethanol coadsorbent. The pharmacokinetics and clinical effects of the matrix patch device are purportedly similar to that of the original transdermal device, despite the absence of a reservoir and a rate controlling membrane. This suggests that skin contact is consequential variable in determining absorption of the pharmacokinetics of fentanyl. So we'll go through some of the stuff on skin and how the fentanyl works and passes through. So fentanyl possesses many of the physiochemical properties essential for transdermal use. As you can see on the diagram while I'm describing this, you can see a cross-section of skin. The molecular weight of fentanyl is about 337 daltons, which is within the maximum weight considered suitable for skin permutation, which is below 1,000 daltons. Fentanyl, unlike morphine and other opioids, is highly potent and produces the desired clinical effects following the systemic absorption of a fraction of a milligram in non-tolerant individuals. Additionally, fentanyl is sufficiently soluble in both lipid and aqueous compartments of the skin to allow penetration. In its alkaloid base form, fentanyl readily enters the cutaneous stratum corneum. This layer of epidermis provides the greatest barrier to the movement of water into and out of the body. Only substances with sufficient lipid solubility can dissolve and diffuse past the ceramides and other waxy lipids of this dermal layer. Subsequent movement of drug from the lipid layer into the aqueous dermis is required to enable systemic absorption. The high lipophilicity of fentanyl results in the rapid diffusion of the lipophilic epidermal tissue, which subsequent slow movement into the water-rich dermal tissue, as you can see in the figure. The results in the formation of a depot, which you can see in the middle, that little circle, and that circle there is the depot that results from the rapid diffusion into the lipophilic epidermal tissue. So what ends up happening is that it allows for a slow onset and a prolonged effect of transdermal delivered fentanyl. The transdermal device application sites are typically rotated to prevent serum concentration fluctuations resulting from development of large deposits following consecutive use at the same site. So I'll move to the next slide here. Let's kind of go through some patch application information. So application site, what are the things to consider? You want to make sure you don't apply on any burns, cuts, irritated skin, or skin that's been exposed to any radiation or X-ray treatment. You want to avoid broken skin. So select a non-hairy area on a flat part of the body, such as the chest, sides, your sides here, the back, or upper arms. In chronic pain use, people are unable to sometimes think clearly, such as due to dementia. You want to make sure that they apply, if they have dementia, you want to apply the patch to the upper back to lessen the chance they might be moved or placed in the mouth. So that's quite important for those that have dementia. If there's hair on the skin, use scissors to clip the hair as close as possible to the skin. Don't shave the hair because it might cause some skin irritation. The other thing to consider is when needed, use water to clean the area. Don't use soap, oils, or alcohol to the application site. What may happen if using these items, you might inadvertently rub in the medication onto the skin that was originally there. Dry the skin well before applying a patch. Don't use a patch if it's broken. I think I went through that. And also make sure when you're removing the patch, you want to remove it from the pouch and peel off the protective liner. Apply it right away to the skin. You want to press firmly with the palm of your hand for 30 seconds to make sure that contact is complete, just especially around the edges. If your prescribed dose, or when you're applying someone's dose, is more than one patch, you want to make sure that the edges of the patch don't kind of overlap each other, and you want to ensure that you wash your hands after applying the patch as well. If people are applying, or nurses might be applying the patch with gloves, just be careful because the patch can tend to have quite an adhesive and it might stick to the gloves as well. If you have any problems with the patch not sticking at the application site, you might try to tape the edges of, with first aid tape. If the problem persists, you might want to ask your doctor, the doctor for advice, or the clinician for advice. If the patch falls off before 72 hours, a new patch may be applied to a different skin site, but be sure to let the doctor know if this happens as well. If you accidentally touch the sticky layer or handle or damage a damaged patch, just wash the area with clean water. The patch comes off, accidentally sticks to the skin of another person, immediately remove the patch. Wash the area with water, get medical help for them right away. Don't use soap, alcohol, or other products as mentioned earlier. So we're going to move on to a little bit of pharmacology. So just a brief little information here. So as an opioid analgesic, fentanyl interacts predominantly at the opioid mu receptor. So when you look at this diagram, you see the purple area there, that's the mu opioid receptor. And you have fentanyl or fentanyl analogs that do act on that receptor. So these mu binding sites are discretely distributed in the human brain, spinal cord, and other tissues. In clinical settings, fentanyl exerts its principal pharmacological effect on the central nervous system. As a general reminder, fentanyl effectively acts on that purple mu opioid receptor, and its mu opioid receptor mediate actions have been subdivided into mu1 and mu2 opioid receptor mechanisms in the diagram. When fentanyl binds downstream signaling to inhibitory effects, this inhibits ascending pathways in the central nervous system, increasing the pain threshold by changing the perception of pain, resulting in analgesic effects. So as you can see with mu1, you have your analgesic effect and what happens there. And with mu2, you end up getting what's known as some respiratory depression, constipation, and also desensitization when acting on the beta-arrestin. So slightly reduced blood pressure, itching, nausea, euphoria, decreased respiration, meiosis or constricted pupils, decreased bowel motility, often leading to constipation, is what can occur. Patches can offer advantages over conventional parenteral or oral routes. They ensure controlled absorption, more uniform plasma drug concentrations. Viability is improved by avoiding some first-pass hepatic metabolism and also enzymatic or pH-associated deactivation. On the chart you see here, when we're looking at Ki, which is used to signify a binding affinity, fentanyl is ranked just below methadone, but just above morphine. So the lower the Ki signifies a higher binding affinity in comparison to other opioids and other medications in this chart. So let's take a look at that for a moment. Okay. So here's a table, table 1. It's the physical and pharmacokinetic characteristics of a transdermal fentanyl device. As you can see, the transdermal device strength comes in different patches. The patches arranged in different sizes as well. So when looking at each individual patch, you can see the fentanyl content that's available and the mean time to maximal concentration and the mean maximal plasma concentration. So looking at this, the surface area, the larger the patch size, the bigger the sticker. So you want to keep that in mind. Also, the time to max concentration takes about 2 days. So the example that you see here, where if you're thinking about writing a prescription for fentanyl, when writing a prescription for those clinicians there that write scripts, physicians or nurse practitioners that write scripts, you want to be specific that it's written like a Monday, Wednesday, or Friday. Sometimes it's tough for patients to plan, over the weekend. Also, if written every 72 hours, planning can't work out well and they have to reorganize their schedule. So it's okay to kind of make sure that the dates are mentioned on a prescription just for ease of use for the pharmacist or for the nurses or even for the patient in terms of just working with the patient on their needs and their goals. After system removal, there's a continued systemic absorption from the residual fentanyl as well, so that serum concentrations fall about 50% in average after 17 hours. I'm just going to show you this next chart here that might describe that a little bit better for you. So on this chart, you see serum fentanyl concentrations following multiple applications of fentanyl transdermal system at 100 micrograms per hour. They used an example of 10 individuals on this chart here. So on your left, you see the x-axis, and you also see, so that shows the number, the left you see your y-axis that shows the serum concentration. On the left, on the right, you see the x-axis there that shows the number of days. When looking at the number of days, and we can go through this a little more detailed, on day 1, as you see the arrow going up, is the initial application of the patch. By day 4, you see that serum concentration increase. And by day 7, roughly, you see it getting to a little bit more of a steady state. So day 1 to 4 is a steady increase, which takes about the second or third patch to get to that steady state. And between days 13 to 16 is where the mean is, where it is at that steady state. And upon day 16, upon removal, that's when I was speaking to, there is still a depot. So it takes about 1 day roughly for 50% and about day 2 for closer completion. So by day 18, you could see that it's almost completely out of the system. So following the system, fentanyl transdermal system application under the skin, it absorbs the fentanyl and the depot concentrates in the upper skin layers. Fentanyl then becomes available to systemic circulation. Serum fentanyl concentrations increase gradually following initial system application. It looks like it levels off around 12 to 24 hours and therefore remaining pretty constant with a little bit of fluctuation for the remainder of the 72-hour application period. Peak serum concentrations look like around 20 to 72 hours after initial application. So the serum fentanyl concentrations achieved are proportional to the fentanyl transdermal system delivery rate. With continuous use, fentanyl concentrations continually rise for the first 2 system applications. By the end of the 72-hour application, a steady state is there and then maintained. So initially, we don't recommend, when going through patch changes, I think it takes a couple patches before you can look at making a patch change. So again, remember that the patch changes that are in place, you can still do add-ons for different patch strengths, just using multiple sites. Patients may reach a steady state concentration that's determined by each individual variation and also the skin permeability and body clearance of the fentanyl. So right now with missed doses, there are protocols that might be coming in place for that. There's a provincial one that is coming out to look out for. Currently, it's in discussion at this time. So I just wanted to let you guys know that. So fentanyl, some counseling key points here in terms of counseling. So for use in long-term chronic pain only, fentanyl patches should be used. Fentanyl patches should only be used, and it is used in chronic pain. So we want to keep that in mind. You want to make sure you're using intact patches. As mentioned, never cut the patches, use damaged patches. It could result in an overdose for excess fentanyl being absorbed through the skin. You want to confirm that there's no allergies to the fentanyl or anything that's made up the patch. Also keep in mind, don't expose the site with the patch to heat. Heat sources such as a heating pad, electric blanket, sauna, hot tub, waterbed, what else do we have out there? Any type of warm plug-in blankets. You want to make sure that you understand that that could increase the fentanyl concentrations as well. You want to avoid any tight coverings on the patch. Strenuous exercise, work, biking, which can heat the body. The body absorbs more medicine with excessive heat. Again, we know individuals do bike and do different things. We just want to create that awareness. So just to have patients understand that there may be a change in the amount of fentanyl that's being absorbed based on the heat that's being created either through sweat, working out, or biking, exercising. So understanding that there is a sign of an overdose or is important. You know, if they have trouble breathing, very shallow breathing, extreme sleepiness, also an inability to think, walk normally, also feeling any feeling like fainting, dizziness, or confusion. That's another factor that could be, you know, reported in terms of a sign of an overdose. With storing the patches is quite important. The safety aspect of storing. Patches should be kept safe and kept far away from reach of discovery of children. Don't let children see you apply the patches. Like I wouldn't call them stickers around children or tattoos or band-aids because this could attract children, encourage them to kind of mimic your actions. So even if you're applying the patch, you just want to make sure that to keep that in mind. Pets is also you know, an important issue. Those that have young pets or even pets in general, you want to make sure that they don't get near the patch as well, because it could cause you know, some issues with them you know, absorbing the fentanyl. So just keep that in mind, especially if we're throwing them in a garbage. So there are other methods that I'll go through in terms of destruction of patches and rather than throwing them in the garbage, and hopefully we can go through that in the next couple slides. So safety is important. You want to fold the sides together. You know, don't flush them down the toilet. Prior recommendations years ago was to be for them to be flushed down the toilet rather than discarded in the trash, just to avoid safety. But my recommendation is to ensure that they're just safely folded and disposed through methods that are in place today, which I'll go through on another slide. Because there's also some medication when you take them off, so keep that in mind. When you take off an old patch, replacing with a new one, medication still exists on the patch. So we want to make sure that that original patch is removed if they're replacing it for the next day, or following up, you know, with the doctor if there's any signs of any overdose as well. It's also not safe for pregnancy or breastfeeding, as it is, you know, during pregnancy, the newborn can get withdrawal symptoms. It also does enter the breast milk. It's not recommended. However, I would recommend in any case of this, there's other options for individuals that are pregnant or breastfeeding to still work with OAT treatment. So move to the next slide. So there's some warnings here. So a couple things those kind of go through. So driving and using machinery, or using machines or machinery or anything that requires full concentration. You want to make sure that you're aware that the patch can cause a little bit of you know, drowsiness. Also, you know, there's a disorder of the adrenal gland. That's one of the warnings. Serotonin syndrome, also another warning. Sexual function, reproduction, fever, and exposure to heat sources, like I mentioned earlier, and of course, the development of tolerance or dependence. So as we go through opioid poisoning, this is a very important topic for everybody to understand. These are the symptoms, know the signs. This comes from Toward the Heart. That's a great website to refer to when you look at knowing the signs, you know, not responding when, you know, when a patient doesn't respond, doesn't move. If they're slow or not breathing, like a breath is every 5 seconds is considered normal. If they're making any sounds of choking, gurgling sounds, or snoring sounds, that's another sign of poisoning as well. So, you know, putting your hand and checking, you know, if there are blue lips or nails, you want to check for cold and clammy skin, and also check for tiny pupils as well. So the recommendation, the serious signs of an overdose you want to make sure that you're aware of this. It's best to have a family member or friend check on people several times a day when starting to use the fentanyl patch, you know, especially even when the dose is increased, if in case that they can get help for you if you can't get it yourself. So this is something that I really, you know, strive to kind of drill down to a lot of individuals. Having been working through the fellowship, I've had cases where had to, you know, be quick and really focused on understanding these symptoms, and you know, utilizing Narcan kit is not something that I'm unfamiliar with, but I recommend everybody making sure they're familiar with that as well. So we'll get into a little bit of pharmacy and important stuff that we look at. Coverage. So on patches, there is coverage with the fentanyl patch. And I'll go through a few things here, and I'll review it on a slide later, a few tips. So special authority lasts 1 year. You want to be best to calendarize this in the office. You know, make sure that hopefully it doesn't fall on a weekend, and also inform the pharmacy. We don't want to run into instances where patients are requiring medication and it becomes more of a clerical issue. You know, the patient needs to continue on this treatment, and especially because it's quite important for all cases that each case is looked at individually. I know that there's a lot of efforts being made, even while I've been working at different sites across all the health authorities in ensuring coverage. It is a topic of conversation amongst all medications and comes up more often. At any point that anybody requires any help or assistance in regards to coverage, my number will be available as well. Or you can call any pharmacy and they'll be glad to help you understand where the coverage is about. So the information is all available on the PharmaCare website as well. So the other thing to consider, so coverage is one thing, prescribing the medication, sending a prescription, setting up a patient, all that can happen, you know, from the physician's office or practitioner's office. But what ends up happening is if a pharmacy has supply. So we've had supply issues with our current chain of deliveries. Sometimes they only deliver on certain days of the week, and not all pharmacies carry this stock. I'd call some certain pharmacies and find out if they carry certain doses, and we all tend to try to work together in the community if it's a community response, but in hospital, obviously they have their own formularies as well. And again, coverage is something that is talked about, but there's also the stock issues that do come about. So the best thing to do is to continue to communicate with the pharmacy, and also when asking if we carry fentanyl, do mention the strength that's being carried as well. If we don't have the strength, we can also combine different patches to make up the strength that you need for your patients so that they're not left without medication. So here are the tips I kind of went through earlier. So just the special authorities, 1 year, pharmacy has supply, ensure that, and make sure just keep open line of communication with the pharmacy. So here's some thoughts that I was thinking about when going through this topic. Initially just talking about the medication itself, and also about current medications that are available in regards to OAT treatment, and discuss why you know, things are happening in regards to different programs. So why is it important that we discuss a safe supply? And why is it that we ensure that there's you know, an alternate? Why is it important we discuss a safe supply, an alternative program within the current landscape of the opioid crisis in BC and across other areas of the world? Is a safer supply beneficial? What illicit opioid substances are people using? Has it switched from the unknowing use of fentanyl when in search for something else to a trend of knowingly seeking out fentanyl specifically? And just to backtrack a bit here, just wanted to keep in mind, supply chain deliveries are key. So with pharmacies, sometimes we can order product and it still isn't available. So that's one little note that I just failed to mention a little earlier, just to keep that in mind in regards to one of the other tips. So when ordering medications by when prescribing medications, it's not just stock issues, and it's just making sure that it's available at the pharmacy. So like we don't know what's happening on the back end, so just call the pharmacy and see if they have the medication at hand. Pharmacies will let you know if they do. If not, they'll order it. We have multiple different manufacturers that we can order from. So we want to just make sure that the patients are looked after accordingly. So I'll go back to another thought. So do we find that there are more opportunities to support our patients and community with treatment options that may be underutilized due to the lack of studies and information in these settings? Is there a place to support the use of fentanyl patch as another agent and the support of people who use drugs in our community? Just keep that in mind. So here's the current stats of the opioid crisis in BC at this time. If we look at the x-axis, that totals the number of deaths and death rate according to the BC coroner's report. And that's the y-axis. And if we look at the x-axis, that's as time goes on. So as you can see, this chart started from 1996 with 300 deaths. And if we go to 2021, we are at 2,232 deaths. The death rate has grown from 7.8% to 43% as of last year. And the numbers here currently are as of January 31st, we are at 207 deaths for the first month of January. And again, this information is available with the BC Coroner's report and continues to be updated. So here's fentanyl's role when it comes to the emergence in terms of overdose deaths. Looking at the axis here, in 2018, we look at a total of 85% illegal overdose deaths that were detected. You can see that red line of unintentional drug deaths, which were including fentanyl, and the yellow is unintentional drug deaths, which were excluding fentanyl. So this paints a little bit better picture for you to understand what fentanyl's role has been in the overdose death rate. And looking at this, it's been a widespread use of this illegal drug, widespread in BC. So comparatively in the US, looking at some research, fentanyl-related overdose deaths accounted for approximately 42% of all overdose deaths in 2017. So in our province, it was 87%. The risks associated with these ultra-potent opioids must be met with an effective system response. The current approach has not been working, as shown by continuously worsening of the ongoing overdose crisis. We need new approaches to be evaluated on a large scale, supported by substantial efforts in clinical research. Recently, a study found that detected urine samples, and there was an increasing fentanyl contamination of street drugs. So more than 50% of participants that were enrolled in an OAT program had fentanyl within their system. So it's a fentanyl-dominated market characterized by regionally produced fentanyl with increasing availability at lower prices. Moreover, while individuals are ambivalent or have negative feelings about the proliferation of fentanyl in street-acquired drug supplies, emerging evidence also indicates that some individuals are now seeking fentanyl, not because of its availability, but due to its increased strength and emergence of high tolerance to traditionally used street-acquired opioids. There are known limitations to the existing OAT options, and there's a need to urgently evaluate alternative strategies for patients who are using illicit fentanyl, not successfully treated with conventional OAT. Many patients may be attracted to and retained in fentanyl-assisted treatment. This may be another strategy for certain patients and prevent harms caused by illicit fentanyl use, including overdose and death. For many opioid users, fentanyl is regarded as the main drug of choice. Here's our current clinical management of opioid use disorder. Many of you are familiar with this. So with withdrawal management, we are using tapered methadone, buprenorphine, or some alpha androgenetic agonists. We also use agonist therapies, and we also use specialist-led approaches. So the treatment intensifies depending where it's needed. And on top of that, we do have harm reduction. So educating, safer use, safer needles, sterile needles, access to supplies, access to supervised injection sites, take-home naloxone kits. All this is very important in preventing overdose and death during this opioid crisis. So a couple things not listed there were the IO and hydromorphone as well. So I recommend individuals that are on the WebEx today or the seminar today to review the risk mitigation. The risk mitigation guidelines have changed and continually are to be updated by BCCSU and the government of British Columbia. So do continue to review the guidelines that you see here. So let's go next. Sorry about that. So I was reviewing some articles that were in some opportunities, but maybe, these are some, options that have been happening. And this article was published, a couple of years ago. So the use of transdermal fentanyl patches who use illicit fentanyl is piloted in Vancouver to address potential version. Sometimes the patch, can be diverted, but however, this is a program that was developed where the patch is signed, dated, and has a film dressing applied, just to help, in terms of each individual patient and their treatment. Evaluation outcomes are still pending, but there have been no adverse outcomes thus far. From what I've heard, the clinical improvements have been noted as well for patients. This is an exploratory therapeutic approach and could be considered across multiple settings and rigorously needs evaluation, as I mentioned earlier. There are limitations due to the limitations with existing OAT. We might find that there are reasons for alternative strategies. Okay, I'll move to the next slide. In Ontario, they did an evaluation of the fentanyl patch for patch program. The patch for patch program is to support safety. For disposal. It was implemented in the chronic pain management in some counties in Ontario between 2012 and 2015. The program required that patients prescribed fentanyl must return used patches to the pharmacy before receiving more patches. The objective was to evaluate the impact of the actual program, and they explored a monthly rate of prescriptions that were dispensed for fentanyl and non-fentanyl opioids, opioid toxicity-related hospital and emergency department visits, as well as opioid-related deaths. When analyzing, they did go over 16 different counties that implemented the patch for patch program, and then they also did a 12-month follow-up. What they ended up concluding is they found that the implementation of the program was associated with a lower volume of fentanyl patches dispensed by pharmacies without an increased use in other opioids. The program had no real measurable impact of opioid toxicity-related hospital visits or deaths. Policymakers should consider the use of the patch for patch programs as part of a larger strategy, also to enhance more of the safety function in terms of using the fentanyl patch. What we have here is one of the examples of a program. When reviewing Teva that does have a fentanyl patch, a generic company, they're using a certain system to help dispose of the patch. What this image also shows is the size of the patch. As you can tell from the markers, you can see the green is the 75, the orange is the 12, And then you also have the 25 and the 100. So this tells you the degrees of how large and how small some of the patches are. The sticker is quite discreet, so returning it is much safer with these programs. I'm sure work sites will have their own programs in place to help support the safety of the patch, and this is one of the programs put out by a manufacturer to assist patients with their clinical goals. So getting back into safety, so there are devices that are available for the proper destruction of patches. This is an easy to use solution that you see there, and it can be used for absorbing medications right on contact. So it's a patented solution. I did a little bit of digging on here. So basically it minimizes diversion and abuse, but the main thing here, and it's called the RX Destroyer, this one version, is a disposal system. So you can use it to effectively destroy thousands of non-hazardous and hazardous medications. So the following is a small example, sorry, for non-hazardous medications. The following is this example. So capsules, pills, tablets, powders, narcotics, liquids, injectables, fentanyl patches, suppositories, creams, and lozenges all can be used with this system. So it's called the RX Destroyer. So that concludes my presentation. I'd like to end with part of what I'm doing with regards to my current fellowship research project. The program that I'm working with right now is with VCH and Harbor Light Detox to help support and give clients an opportunity to review their overall time spent with our wonderful detox team during their treatment and assess their expectations and outcomes. So we've got a detox quality improvement survey. It's a multi-step collaborative process that we're using to develop mixed methods of qualitative and quantitative self-administered survey with support from a staff member if required. It's only being issued out to clients who use opioids and kind of going over their experiences. So understanding patient experience and preference in withdrawal management settings in an era of increasingly strong illicit opioid supply is important due to the limitations of treatment with conventional OAT. So there's an urgent need to consider other treatment strategies to prevent harm resulting from the illicit fentanyl use. So hopefully, as this project continues, we'll be able to get some more data and work with more clinicians and educators in order to find more solutions to support our community and prevent the opioid crisis from continuing to get out of hand. I do appreciate everyone's time with the presentation, and I'll just throw up some references that I went through here and some more information. We have the addiction medicine clinical support line, clinician support line. So there's the number there. It's available 24/7 for any questions you may have. In the consultation is for physicians, nurse practitioners, nurses, midwives, pharmacists, and available anytime. There's information and the website listed there. And that concludes my presentation. Thank you very much, and I appreciate your spending some time this afternoon with me.
Thanks, Rahim, so much. And I'm just seeing if there's questions here. There's one just asking about, when you're applying patches, let's say there's multiple patches, what if the pharmacy doesn't have 100 micrograms once in a while because maybe there's a second patient that came in that needed certain things? Like how best to put things together, and what's the space like to apply the patch? Can it be on one side? Does it have to be in one area, or how does that work?
Yeah, so that's a great question. Thank you, Mona. So with regards to patches, during consultation, we usually describe, and inside the package of patches, there is an insert that actually shows descriptive of where they can be applied. There are multiple areas on the body that they can be applied, against the arms, the trunk, on the back, on the chest. And with regards to patches that if you don't have the strength, a total of 100 microgram, you can then combine patches to make up that strength. So hopefully, if the pharmacy has other strengths available, they're able to add 2 patches together and just apply them on 2 different sites. The key point is to apply them at the same time, and if using them for 3 days and let's say stock comes in at 100, we want to make sure we carefully remove both patches and then apply the 100 microgram patch in another area as well.
Great. And a follow-up to that, somebody was asking, how about taking showers? Can a person take a shower with a patch, or are there any hints or tips that you could share with us in terms of informing the patient on what to do if they're having a shower versus a bath?
Yeah, definitely. That kind of relates to my earlier information on heat. So when taking a shower, yes, you can take a shower with the patch. You want to make sure that you're not showering and you're excessively showering and adding heat to that certain area. So you want to be cognizant, just aware of that. Other things that can be considered if there's concern of patches falling off, you can tape the patch on sides, or you can apply a dressing on top of the patch if you need it for a short period of time. But the recommendation I have is just to make sure that just to have that patch awareness, and if it is in contact with a lot of heat, you want to prevent that absorption, because you don't want to get into a state where there's more fentanyl being absorbed and therefore going into more of the side effects in terms of toxicity. So just keep in mind not to just have the shower going off with excessive heat in that one area. That will be what my information is there.
Okay, thanks. Don't see many other questions, but if there are questions, you can email them as well, and then I'm sure Rahim can follow up with that. I guess we'll end this session, but thank you so much to Rahim, and also on the back end, you might not know, but we have our coordinators in the back end helping us, Raman as well as Jamie, who's new. So we really thank you for you guys taking the time. Oh, there is one more question, one more. So who makes a good candidate for fentanyl patch as for opiate agonist therapy, and are there certain criteria that can be met? I can answer that one in general right now. There are provincial programs being put into place right now, and that's forthcoming. Nikki, that has asked that question, but keep an eye on that. Everything is in the works right now for certain things, and of course, stability would be something to consider. So thank you for your time here, and I will end with that.
Perfect. Thank you.